2 months after injury. We see this in day-to-day functionally when they are not operated or conserved, or even some of them which are in plaster. They are okay if the patient is above 70, but not if he is 30. Easiest things. Now Broadstone has beautifully mentioned this, showed that in cadaver study that the shortening of the distal radius by 10 millimeter reduced forearm pronation by almost 50% and supination by 30%. I doubt very much. I think this is a purely laboratory function. Best function, we all know this, figures. So extra-articular correction is always very successful and is worth doing it in young. This was the defect which was there, and this could be very well corrected with the osteotomy and this plating which has been done now. You can get probably the correction and the best possible result. Functionally, it would have been all right, even like this. Functionally, this is a minor disability, but that in a younger patient can be very well corrected. Now, we come to this sort of angulation in a young patient with the shortening of the ulnar, so that we know that it has been a collapse which has occurred. This is the one which needs really a surgery, because this problem gives you quite a lot of problems into supination pronations. And in these situations, you can go down, do the correction of the deformity, and also in past we all did the excision lower end of the ulna, which probably gave us a fairly good results. But nowadays it is not only the excision, you have to also anchor it with the extensor tendon there, and then it gives a good result there. Obviously, you'll have to pre-plan the situations from the correction which you have to do it for this, how much of the osteotomy which is going to correct, so the tracing which you do it, and then execute the surgery. This was done about 30-40 years back, which I remember. So it's still very easy to do it. This is an ordinary plate which I had used it. So it's much easier, even if the dorsal plate, an ordinary plate, still you could really correct it very well with a good function. Obviously, the dorsal plate needs to be removed. This is now the intra-articular problem. This is where the surgery of this which was taken over. Somebody had done this intra-articular fracture with this plating, and there was a marked stiffness which was there. So 4 months post-surgery, minimal movements at the wrist, and a constant pain. Surgery at time can harm if not done okay. Now this is the CT scan. This is irreparable. Don't try to do anything. If it is in a wrist joint, I feel, if it is intra-articular, you really cannot try to improve upon it much. So this is a 4 months impaction fracture. This is where in my enthusiasm, impaction fracture which was painful. I had a CT scan, but I couldn't trace it. But this is the one which is impacted fracture. I went down and tried to get the impaction corrected. Tried to do lots of things there, but ultimately all these leg screws and these Herbert screws, ultimately the intra-articular fracture, I couldn't really do much. It ended up, that's the reason I was asking that question to Dr. Chowdhury. There is an intra-articular fracture which has occurred, the fibrosis. You couldn't really get anything much going. The same pain remained, ultimately ended up into an arthrodesis. This is the type of an arthrodesis ultimately it ends up into. Now here was the fracture which had a second fracture occur at the tip, which is much easier to correct with the small osteotomy. Is not worth accepting it because it's only a cosmetic deformity, not a functional deformity. This was a medical student. This was a medical student which had this. Best of the surgeons in the medical college operated upon this. The wires came out, they walked out, the external fixation which was there, and this is how you can see the deformity which has occurred. Intra-articular fracture again. So again, this was the second surgery which was done by the surgeon. I have not yet taken over, I am just coming into this picture. This was the second surgery, somebody did it, and then it went into non-union, the plate broke down. Now at this stage, the very experienced surgeon took it over, and then he started distracting the radius. We started distracting the radius in order to get the radius length. This is what was done by the two very good Aliza Rao and the hand surgeon, and then it ended up into this non-union. This is the stage when I took over. This was a medical student. You can see the joint is almost completely gone. This is the one which I took it over now for the radius non-union. This is the one which I went down and did Kaptanchi and this grafting and everything which was done. But you can see this screw. This screw is, there was no lower end of the radius. This screw is biting onto these carpal bones. You can see that very well. It is biting onto the carpal bones. Now this is the fracture which I had advised at one stage an amputation. Sorry, the arthrodesis. And the patient says, medical student, sir, but I can move this wrist. So I said, fine. We went ahead. I learned at that time. I went ahead. I did. Everything is held up. You can see the screw is biting onto the carpal bone there, onto the distal row, onto the proximal row of carpal. This is a video which is not working, which is a good movement, but you can see this. वीडियो उधर चलता था, इधर नहीं चलता है. इस वीडियो उधर चलता था. There it is. Now you can see the movement occurring. This is not movement occurring at the distal carporadial joint. This is the movement which is occurring at the intercarpal joint. Still he has an excellent range of movement, about 60%, 70% range of movement. I see him because now he has become a full-fledged orthopedic surgeon. It's a good range of movement. So it is not worth doing an arthrodesis of the wrist joint. Even if there is arthritis, probably if you conserve it and remove the pain of that distal radiocarpal joint, he will still get a range of movement. And this is the last case. This was again a non-union, which was again a perfect range of movement, and everything can be handled into this sort of a non-union also. Here is this 78-year-old active man, me. I had this fracture. Typical Gujuba, I didn't want to put into plaster and anything. I went on operating myself, took out the splint, went on operating because I felt this is just a small crack fracture. It doesn't need anything to be done. It went on in 8 months' time. This is what was the deformity. You can see the CT scan. Somebody suggested we go ahead. Initial options given by different surgeons: arthroscopic suture of TFCC, Darix, Capadanchi, ulnar shortening. My most trusted Sudhir Warrior gave options but no definite directions, gave answers of. He ultimately left to Randy. Radiology opinion was taken by Sudhir from JC Jupiter and Diego Fernandez, and they said, you must correct the deformity. I wasn't really willing for correction of the deformity, iliac crest graft, putting in the graft, and all those things. I wasn't willing for that. And then ultimately, Randy Bendra did a ulnar shortening. This is all what was done because I was getting this pain over here, and I was getting this pain. So that's the reason why the Randy Bendra did this ulnar shortening, and you can see from here to just a little shortened ulnar. And there it is. I'm 100% fully functional with this deformity, which doesn't really give me any problem. This is 100% range of movement, playing golf, playing well, earning money in golf. So in conclusion, shortening ulnar now is a better solution than a Darix or a Capadanchi. So probably you should learn to do this shortening of the ulnar. Thank you very much.